at the moment. All you could do really is say, well, these are the patients today or this week that we need to identify as patients who are serial DNAs and take the normal necessary steps like send them text messages and ring them up and things like that. So let me just share my screen, see if I can find an example of that. Got a live practice open, but I've hidden the patient identifiers, so we should be fine. Appointment reports, DNA probability report. So you can say, let's show the top 50 patients in and put a reporting period that you're looking for people who've got appointments over. And off it goes and gives you a list of said people, and then you can sort them. Obviously, it's going to take a little while. I'll come back to this later. Sort them in the order of those people who score the worst, who have got appointments coming up, and then you can contact them. Let's leave that for a little while and see how that goes on. So that's DNA probability. The other one is, which I think we've talked about before, patient insights, which brought up a bit of negative thinking, really, because, well, I don't know about negative thinking, but it makes people think about if we've got this feature, patient insights, where we can see for some given conditions, and here they are, cancers, what patients are not diagnosed with these conditions, but AI suggests that they might have them by looking at various things within the patient's records. And I guess the worry, I imagine, for GPs is once we've seen this, we can't unsee it. And will people be expecting us to do something about it? And that might be manageable with given this number of people, but if it were to include a lot more conditions, would we be able to do anything about it properly? It could be that you have people within the practice who focus on this sort of thing, in which case this is a great tool. These people here have things in their record that suggest they have bladder cancer, bowel cancer, cirrhosis, ovarian cancer, uterine cancer, those things, and ranks them again in the practice for those people who have got the most things that's possible in their record that suggests they do. These little icons on the right-hand side indicate they're in more of these tabs. So if you hover over these, it'll tell you, bring that back a bit, that person, as well as being on the uterine cancer, is also in the ovarian cancer tab as well. So I don't know if we got anybody on the call who has any concerns about that or thinks it's best thing since sliced bread. Have we any thoughts about how that might be used? I think it certainly makes you think about these tools and whether, if you're presented with them, you can have to do something about it.
I've just realised that because you're presenting, you're probably not seeing people's hands that have gone up.
Oh, sorry. Right. That's true.
We weren't all going deathly silent. I had my hand up. So for me, we've just recently got the Curiosity tool that's going to help us with our ICB-LCP types of work for us cohorts. I noticed when I was looking at that, it did definitely have a section with regards to these are the long-term conditions, and of them for us, cancer was pretty much up there. So I could see that rather than waiting and hanging around for the Curiosity department to give me the patient information because at the moment it's just a generic, not a generic number, it's a non-identifiable number. I have to send it back to them for them to tell me who the patients are, identify their NHS numbers. So I could probably just do a quick look on this and probably correspond the numbers side by side and start the work whilst I'm waiting.
Indeed. And do you have like a special responsibility within the practice? Is the practice identify somebody as somebody who could look at these sorts of things?
I think for me, it's just I'm practice manager and I work quite a bit in the PCN as well. And it's just figuring things out as to, well, is this how I would do it? And if this is how I do it, then I'd train and pass on then to the team and say, this is what you need to do to assist with this work.
Yeah. Cool.
Yeah, all I'm thinking, Nicola, is it could be a completely different cohort of people to the cohort that's been brought up by that Curiosity tool, which is pulling on data from these data models. Doesn't necessarily mean that's a bad thing. I'm just saying, I think they're probably looking at very different things, but I might be wrong.
Even if they're looking at different things, if it's still a patient that's identified with that condition, that prognosis, then I could be theoretically hitting two birds with one stone.
Yeah.
Well, Guy, you've got a couple of hands up.
Yeah, I suppose you have to proactively run the report, Andy, don't you? Because I think ethically, if you've run the report and you've got a list of patients who might well have cancer, then ethically you're going to have to do something about it, really. If I'm a patient and I'm on that list and nobody's contacted me, I won't be very impressed.
Indeed.
I think Alexis has got a hand up.
Alexis?
Hi, yeah. Is it okay if I ask about the first AI tool you mentioned that's not ready? So is that kind of like the Scribe software so here at Wesley's PCN, we're trialing out the Heidi AI Scribe tool to help with consultations. So we have it with the social prescribers at the moment. So is that kind of what that AI tool is like? I mean, obviously I have my concerns about it just because obviously, you know, it's listening to a two-way call to help write the notes and everything to put onto the system. I suppose at least with this, it is in SystmOne. So I was just wondering, is that kind of what the tool's going to be, where it's helping to input that data into a consultation?
Well, we hope that it's going to involve a little bit of digital dictation and that like as well. It's a little bit quiet, to be honest, from TPP on this. They have mentioned it a couple of months ago, but I've not seen anything else since then, and it's not available as yet. But it is supposed to, as well as doing that, also look at other aspects of the patient's record while you're doing your consultation in case there's any bits that you've missed, and kind of like pop them up as well.
Okay, yeah, because I think I've seen a bit of that as well with, and I know Amelia know this with the Joy software we're also trialing out, where it kind of has the insights as well with, you know, if what would it be best to be referred to, whether it's like, you know, if it's social issues or housing issues as well. So obviously there has been a bit of trial here at Wesley's PCM with different ones. So I suppose that this might help with alleviating having to use third-party stuff like the Heidi software.
Well, indeed. Yeah.
Have you heard that he's going to do Scribe though, Andy? So I thought the new clinical assistant thing was going to actually be a patient by patient prompt around missed diagnosis and stuff like that. That's all I'm hearing, but you might have heard more.
I'd heard that, and I'd also heard a little bit of about, you know, scribing as well.
Right.
Included in it. It's a little bit tricky because I think SystmOne do get round to things. You know, it's not kind of like EMIS where you're waiting 2 years. So they do get round to things, but they realise that there are a lot of third-party organisations that are ahead of us at the moment, and I think they're trying to put these things out, that and the new document management system, to say, look, it's coming. We promise. You don't have to go off and find these third-party tools. Because I mean, I don't know about you, but I have about 4 different toolbars popping up all of the time. You know, with my AccuRx and my patches and various bits and bobs, and they do. It does tend to be a bit of a faff. Whereas when eventually SystmOne do it, they will build it in, and it won't be as faffy as that.
Yeah. Oh,
Cool.
Nicola's got her hand up again.
All right. Hi, Nicola.
Hi, sorry, just picking up on I think it's called AVT, Ambient Voice Technology for TPP. And when I joined the video demonstration that they did, I want to say it was about 2 months ago. It sounded very, very similar to Heidi Health, in that if you buy the pro version of it, it would not only just do the transcription from speech, but it'd give you templates that you could push it out to, but it would also then update. So if the patient told you what their blood pressure was and you were discussing that, not only would it put it in, but it would also code it.
Mm-hmm. Mm-hmm. So
it did sound better.
On the trial? They were asking for some people for piloting it, weren't they, or something? Did you manage to put your name forward or something?
We put his name forward for that, but to be honest, it's the document that they mentioned quite recently.
Yeah.
The document manager that I'd really, really be interested in.
Yeah.
Cool.
Okay, Andy, I think we're running a bit behind, but have you got the next section as well?
Yes, so it's next bit. Just a quick note on GP Connect. So we've been told that we now need to open up a new section, which I think has gone out to all practices. So in setup, users and policy, and organization preferences, if you search for GP Connect, there are 2 areas to GP Connect. There's appointments and there's record sharing. So I'm just going to see both of those come up in a minute. There we are. So this is the appointment section, and it's not about that. It's all about interoperability and third-party patient record settings. So this is the minimum requirement that the government say we need to have. And this bottom one here, enables structured access, was the one that perhaps practices don't have. And when we're doing BARS referrals, it enables the selected organizations at the other end, including pharmacists, to see fairly detailed information from the GP record. And so many practices might have a couple of these ticked, but legislation now says we should really have this third one ticked in here as well. And I've had a few calls this week, people saying, oh, I understand there's this GP Connect thing to do, and they're looking in appointment provider and consumer, but it's not there. It's down in this third-party patient record settings. Just linked to that is the BARS referrals themselves. So
Andy, could just go back, the incoming messages, just on that other bit, you also need to have incoming messages switched on. So you need to also be enabled for the pushback for the incoming messages. So otherwise they'll be coming by email. So that was the other bit of the contract.
Yeah. So that's on incoming messages here. So it's enable auto filing of third-party immunizations, and then down here, your GP Connect settings, you have to decide as a practice whether you want these to be filed straight into the patient's record, or you want them to come back as a task that you can then open the task and decide whether you want to file that. And also be alerted to the fact that there is something to see, whereas when it's auto filed down at the bottom option, you don't get that.
But they will both send a file. So even the file automatically will send a file to review it. So both of those options will, and it's up to you which you pick, but you can't have it turned off is the current position.
Cool.
But both of those options will send a task. One will already file it and say review it. The other one will just send a task
Alert
saying
you to the fact that it's there. Yeah. Cool. So it's a little bit like auto filing of results in a way that it's there in the record to look at and to trigger protocols and things, but you kind of like alerted to the fact back on the investigation screen, that you still need to review that. And that's a little bit of a confusion as well. I get a few calls about people saying, why has this result been auto-filed when it's clearly wrong and needs some action taking? But actually it has been auto-filed, so it's in the record for people to view and to trigger protocols, but it's not been reviewed yet, and it will still remain in the pathology system, in the pathology day list for you to review, much the same as these. So actually, that would seem a sensible option, but I'll leave it on this particular practice there. And for bars, tomorrow, SystmOne are changing it so that bars referrals appear in reporting as well. So in effect, that might mean that we don't have to read code them, but our advice just for the moment is to carry on read coding bars referrals. So don't do them directly, but do them through the blue dot. Go to your pharmacy first option. And basically we're coding whether it was a successful referral or whether it was declined, which puts the codes in which we can then report on. And then go into the bars referral down here. Also gives you the option of updating contact details for your patient at the same time.
I think, Andy, that ability from well, it'll be Friday when it's actually switched on, won't it? Be tomorrow night when they do the update. The ability to report on the bars referrals should then allow practices that are concerned that they may not have coded things. They'll now be able to create reports to check what's been coded and what hasn't.
Cool. What else have we got on our list? Let me just have a quick look. Wrong one. Insights we've done. Open safely. Perhaps.
I think they covered that in the first session. If anybody joined,
right,
and
cool.
I don't know if anybody, you just want to paste the links. If everybody was in the first session, Blaine did cover it. I don't know how many people were in the citywide session.
Probably everybody. So
just stick the links in the chat in case anybody wasn't. But
you want to pop those in for me?
Will do.
Thank you very much.
There's a question on frequent attenders, I think, next. And
all right, frequent. Yeah, I think this was from Alison, wasn't it, last time, saying, is there anything we can do about frequent attenders? And nothing fixed in SystmOne, but we could write a report to find those. So in clinical reporting, we could basically say we want to find people who have had appointments over the last maybe 3 months or something like that. So if I just do one. And then we could break that down by what type of rota they were in or which clinicians they were seeing. So I could put this frequent attenders. See where I can stick it in your folder there, Craig. So the category appointments. Right, so in administration then we've got appointments we can report on. So we can say has an appointment here. The appointment date could be after 3 months ago, perhaps. And that's it. That's all we can really do on there. So we'd okay that. And then we'll run that one. So 2,858 patients had an appointment over the last 3 months at this practice. Now we'll break that down. Basically, you'd want to break it down by probably the patient's name. I don't want to show names, so I'm going to just stick on a patient ID to break it down. And then in the appointments, then you could break it down by who they were seen by, what rota type it was, maybe. And up at the cross top here, tick item count, which is going to give us a count of the patients, which allows us to sort them into our frequent users. So I'm going to click refresh now. I'm just going to sort by this end column. I've got a lot of X's in here because I've turned off patient identifiers, so we don't see any patients' names.
Where's your item count gone there?
Where is my item count?
That's the column you're on, yeah.
Oh, yeah. That's the one I was looking for, yeah. So there we are. So we've got one particular patient has had 38 appointments over that 3 months period. It would have listed the clinician they were seen by here, what rota type they'd attended over there. I don't know why that's particularly needs to be crossed off, but there you go. But on your reports, these two columns here will show who they've been seen by and what sort of appointment that was. If you're sorting by these things, you're probably better off sorting one at a time. So if I just do it by clinician, that 38 might go up actually for that patient. No, it stayed the same. And then do it by clinician if you want separately. As to what you do about that, I don't know, but you can at least identify who these patients are and try and take some appropriate action. Anybody got any questions about that? Yeah, thanks, Alexis. I was clicking the wrong column. Cool. Well, I think that's me done, unless there's any other questions. Hints and tips. Could use function keys. Control N goes to your document management system, so it's nice and quick. Control T goes to your tasks. Control F, when you've got a great big list up, allows you to put a search criterion and go down that list. So it's the list of staff or a list of patients or whatever. It will find them in that list. Other than that, I think that's me done.
Okay, Andy, thanks very much. Next on the agenda, we've got list maintenance with Vicky. Is Vicky on the sorry, is Vicky on the call?
I'm not sure whether she's joined, Guy, just because the agenda it's 20 minutes from now, but I can do my session on proactive care if that's okay.
Okay, yeah, we can switch it around. Yeah.
Yeah, thank you. Just bear with me, I'll just log on to practice so I can get a test patient up. Sorry, just bear with me. Okay. I'm just sharing my screen. Okay, can everybody see my screen?
Yeah, that's fine.
Okay, lovely. So for those of you who don't know me, my name's Anna. I work in the data quality team. So I've been working with colleagues in the ICB and from some EMIS and SystmOne practices to support with the new proactive schemes that are going on. So for the purpose of this session and update, I'm going to be focusing on the targeted cohorts, groups 1 to 3. So there was guidance went out in the primary care bulletin last week, and it also went out in the data quality bulletin yesterday. And it's quite a comprehensive guidance that includes information on what the scheme involves, a breakdown of the 3 targeted cohorts, so group 1, 2, and 3. When you have chosen what, I'll show you on this page here. It basically it's based on this national proactive care framework. So we're looking at the 5 core components, and essentially that's looking at identifying the target cohort, carrying out a holistic assessment, developing and personalised care and support plan, developing coordinated multi-professional interventions, and then providing a clear plan for continuity of care. So to support practices with identifying the target cohort, data insight reports have been provided to PCN and LCPs. So some of you may already be aware of that already and may have had those conversations with colleagues in BI. So the data insight reports will help inform the identification for your local population. So as you can see on the screen here, and apologies, the wording isn't very clear, but it's been split into 3 categories. So population 1, which looks at patients with moderate or severe frailty, and then population 2 is patients with moderate or severe frailty, and then 3 renal metabolic conditions, and then population 3 again is people with at least 3 renal metabolic conditions. Some of you might have already some of you might not be looking at these targeted cohorts. You might have already decided to work with a different proactive care scheme that's going on across Leeds, and that's fine. So some of your PCNs might be looking at working with the Healthy Working Lives, or might already be doing work on advanced respiratory. But the guidance that was shared yesterday and the reports that I'm going to show in this session are linked to these 3 cohorts, so population 1, 2, and 3. So I'm just going to demo it to you live with you now. So what we wanted to do is, because there's so many different proactive care schemes going on across Leeds, we wanted to have a central landing page really for proactive care, where practices could go to that page and find out what they needed to do for the scheme that they're involved in, on which template, where they needed to go essentially. Because there's quite a bit of crossover across all the different schemes, we didn't want to make one massive long-term condition template. So essentially how we've designed it is that you'll come to the ICB blue dot, you can go onto the proactive care page here. And as you can see, what we've done is on the left-hand side, you can see there's sort of like a contents panel. And depending on what your practice, what scheme your practice is working on, it has a little bit of advice or guidance about where you should go. So for advanced respiratory, you click in and go to that specific pilot template. So for the purpose of looking at the targeted populations, group 1 to 3, you would essentially come to this page if you wanted to. At the top, what we're recommending with support from colleagues in IG is that when you are onboarding patients onto the scheme that you discuss, are they aware of what the scheme entails, and do they consent to participate in it? So in here, there's a question where you can just tick to make sure that that is recorded in the record. We're currently working on a letter as well with IG that you can use and share with patients when you are doing onboarding, so you can send that out to them. Just has information about what's included, where the data is going to be going, if it's going to be going to other neighbourhood teams, things like that. Underneath, there's a section here for proactive care coding. So these 2 codes here, as you can see, there's a description above next to each of the headers. So provision of proactive care and proactive care ended. So both of these codes are included in the national DES contract. So they will be used across all of the different proactive care schemes. So if you are working with the targeted 1 to 3, you can use these codes, or if you're working in advanced respiratory, you can use them as well. And there's a little bit of guidance as well on when we suggest that you should use them. So input assessment, or you say proactive care's ended when a plan has been put in place, and agreed follow-ups. Further down here, there is a little section on targeted population groups 1 to 3. So again, it highlights if you needed any reminding what the population groups are. When you receive, essentially what will happen is once you've chosen your population, whether it's group 1, 2 or 3, you'll be provided with a patient list, and you will need to re-identify that patient list within SystmOne. So in the guidance document that went out yesterday, and if anybody didn't get it, I'm happy to share it afterwards, it has information about how you import that list into SystmOne, and it essentially creates a group and a report within SystmOne so you can re-identify the patients from that list. Once you've got that list and you've decided which of the patients you want to work with or reach out to be involved in the proactive care scheme, we are asking that practices add in this re-identification code. This will allow you to track those patients within your practice to say that this patient's part of our targeted population that we chose to work with. Depending on whether you've chosen population 1, 2 or 3, we were suggesting that you could come here to record the proactive care codes and then go off to use the relevant template for that particular patient. So if you chose population 1, you could use the frailty template, or if you chose population 1 and 2, you could use the frailty template and then another long-term condition template of your choice, depending on what the patient has. So that is essentially what this repository page looks like. We also have a link here to the EQ5D5L, which is a health questionnaire, and it essentially, you can add in a score for mobility, self-care, usual activities, pain, discomfort, anxiety and depression. And you can see here there's like a couple of options that you can select where you can sort of say, I have no problem with walking, and that way you can it adds in like a score linked to each of the questions. Our evaluation team are planning to use this data to track whether there's been any improvements or declines with the patient's health, for those patients who are participating in the scheme. So where possible, if you could try and record the consent to share that data, that would be really appreciated, or have that conversation with the patient at least and record their consent preferences. The recommendation from our evaluation team is to try and do the EQ5D5L at onboarding, and then again at 3-month intervals. Okay, so that is the template. I'm just going to come out of here now and show you where the reports are. So you go into clinical reporting, and then if you go to leads, ICB leads, and then they're just in the 25-26 proactive care folder, and they're really basic reports. So in here, if you wanted to track yourself and review the patient's EQ5D, 5L scores, you can have a look at these reports in here. Underneath this is just the generic proactive care DES code, so you can see as a whole how many proactive care codes have been recorded. And then underneath this links to the targeted population cohort. So at the top you've got, once you've re-identified your patients and you've chosen who you plan to work with, if you add that re-identification code on, the patients will appear in this report, and from there you'll be able to see how many of those patients have had proactive care started and ended as well. So yeah, that is a quick run through. Like I said, there's quite a lot of information and guidance available in the data quality guidance that went out yesterday. I'll pop my email in the chat, and if anybody, when they come to receive the data and they're re-importing that list into their practice, if you've got any questions or any feedback or suggestions for the template or tools that we've got, then please feel free to get in touch. Does anybody have any questions at all?
No.
Okay, brilliant. That's lovely. I'm hoping that Vicky might have joined the call now. Vicky, are you on the call?
I am, yeah.
Lovely. If I could just hand over to you then next. Thank you. Thanks, everyone. Bye.
Thanks, Anna.
Okay. Can you just confirm that you can see my screen?
Yeah, that's fine, Vicky.
Okay, thank you. Okay, so I've been with the data quality team for about 10 months, and one of the projects that I've been given to do was the list maintenance, which I didn't know what that was until I looked at it and discovered it's what we all affectionately know as ghost patients in practice. Patients that have somehow stayed on our records, stayed on our practice list that maybe shouldn't be there. So we looked at how we could develop a template and some searches to help practices clear up basically those patients that really should be somewhere else or have gone somewhere else. Just give me 1 second. Right. So we know it's part of the routine work within practice, and most of us do it. Most practices do it, and they'll have a time during the week, month, or whatever where they will go through it. But it's good to have a process in place. If you haven't already got one, we've put a process together for you so that you can use it. It's just a suggestion. So we've put on the searches, the data quality team, I've got some under the data quality toolkit called list maintenance, and you will find searches that have been created for you to find patients that are within certain criteria. So some will be that haven't had an appointment within the last 5 years, some that have been registered for over 5 years, some that had a date of entry to the UK, overseas visitors. So patients, basically what we want are patients that we've not had contact with in one way or another, whether that's a telephone call, whether it's a request for medication. So we've put some searches together to make it a little bit easier for practices to try and find those patients. We've got a couple of codes for practices to use if the registration data is unknown, but we've also put it in the template for practices to use within the template as well. And we've got a code for patient registration data verified that we've put on so that when you do run these searches, those patients will have dropped off. So we've put together, if you look at number 5, we can look at what work to do there will be for the financial year. And we've suggested using letters if you want, or text messages, SMS, text messages, patches, emails, whatever your practice uses normally to contact patient. Bearing in mind, you've probably already tried contacting these patients for various other reasons over the time. This is like a last stop that we want you to try and use to sort of say to patients, look, we've not heard from you. This time, if we don't hear back from you, we will have to start the process of deducting you because, you're obviously registered somewhere else or you're no longer in the country. You can access the template if you use the search bar at the bottom left-hand side and type in list maintenance. You will get access to the template. It's very straightforward. I've worked in practices, so I know the less work for reception team, admin team, whatever to do, the better. And it's literally just a tick. Patient registration data unknown. If you get something back that tells you that patient's no longer at that address, no longer in the area, this can be ticked off, and it will no longer come up on your list, on your work to do list. You've got suggested messages for texts and emails. You don't have to use them, they're just suggested. The letters on a Word merge document, or you can go into it via the template, or you can do it separately. It's depending on how your practices work. Some practices still use lists, printed off lists to do their work. And you can do either bulk letters or bulk texts to send out. And these are literally just suggestions. They're not set in stone. You might have your own way of doing things. So it's just to help you give a little bit of assistance. There is a guidance, a more comprehensive guidance that will tell you how the searches work and how to operate those searches, but hopefully it will just make what is really quite a monotonous job a little bit easier, because we all have to do it. So hopefully it will just give you a little bit of a help to do it. And that's all really. It's fairly straightforward. If there's any questions, that's absolutely fine. Okay. All right.
Okay, thanks, Vicky.
Thank you.
We've next got new patient registration consultation with Jemima.
Yep, hi, I'm here. So I've got a new template to showcase for you guys. It's not published just yet. The sort of purpose of this is to sort of get some feedback. I am aware a lot of practices are now using either the TPP auto reg, and some of you are even using, I think it's the HealthWatch auto registration functionality, but this template was sort of created to match the new online registration form. And there's a lot of the similar sort of aspects on the form that's on here. So I'll give you a quick overview, and if anyone's got any feedback, it'd be great to hear. So on our first page, you can see we've got a bit of information about sort of the regulations. Oh, I'm not sharing, that would help, wouldn't it? There we go, can we all see it?
Yeah, that's fine.
Yeah, brilliant. There we go. So as you can see, we've got the, like, as I say, regulation sort of information on about patient registration. We've got some really important codes here, such as, you know, the notes summary, the on the computer. You've got your ID verified, and sort of what's happened with the Lloyd George paper record notes. We then have some quick action buttons where you can go instantly amend patient details and address. We then have some extra stuff here, but a couple of these things aren't coded as such. They've got the code patient registration data behind them, but it's quite good to sort of know where the patient has moved from, you know, what their last address was when they were at that previous surgery. And then also, very importantly, we've got the emergency contact details and next of kin. We also have a quick action button to security control procedures, which is also important. We then move on to further details, which is more sort of in depth on the patient's sort of health journey. You know, what the mother's address was when the baby was born, if they're under 12 months. We've also got patients under 12 years looking at things, are they looked after, are they in education? We also have a link to the child's safeguarding template, IMS and VACs, and for you to record school here. Sort of other reasonable adjustment information, such as interpreters. Do they need an interpreter? What kind of language, you know, what language do they use? Should not have clicked that, it was going to crash it now. Well, that loads. You can also see we've got online services, we've got record restrictions, you know, if there's any sort of safeguarding worries. A carers section, are they a carer themselves? Is it informal or occupational? We also have, you know, option to add in the carer's information. There we go. Carer's information, carer's needs. If they're an unpaid carer, do they need assessment for more help? Information sharing, you know, your important stuff such as the SCR core data set. Do they consent to having text messages and emails? And here you can record the current GP and also nominate them a pharmacy for EPS. Again, a bit more about the patient's health. It's important to note that in this section, that it's just free typing, so these conditions aren't coded. This is something that should be done during the new patient consultation, also known as the patient health check, which we will be developing a sort of counterpart template for later on with some clinical input. But for now, this is what we're working on. A bit more information about height, weight, smoking. You can record pregnancies and pregnancy expected due dates. And then we've got the audit C calculator and how often the patients are sort of drinking alcohol. You know, all relevant information for the new patient health check. Again, these are non-coded. These is just to give the person doing the new patient check more information, you know, things to look out for, such as allergies, mental health conditions, disabilities. And then next to disabilities, we also have a link to the reasonable adjustment template in case the patient needs any adjustments making. Then we have patients from abroad. You know, if the patient is visiting the UK, doesn't normally live here, currently live in the UK, but it's not their permanent country, etc. Then we do have some non-sort of coded bits of information here regarding if the patient understands if they have to pay, if they don't know if they have to pay, or if they know they don't have to pay. And then we've got some other sort of non-coded parts here just about, you know, if they've got forms, if they've got an EHIC card, etc. And then here's where you can record EHIC information, such as, you know, the date of birth, their ID number, etc. So yeah, that's really it for the template at the minute. It's just dependent on, would you think it's useful? Do you think there's anything missing? Do you think there's anything there that you wouldn't necessarily do through a template? Just trying to gather some feedback at the moment. So obviously, if you can't think of anything now, that's fine. I'm going to pop my email in the chat. But if anyone's got any questions or anything now, would be great. No, that's fine. I've popped my email in the chat if anyone has any thoughts. Thank you. Think you're on mute, Guy.
Yeah, thanks. Yeah, I think that's the agenda. So we just got any other business, any other questions? Right. No. Okay, we're finished half an hour early, which is good. So enjoy the rest of your day.
Thank you.
Okay.